আমি ঢুকতে যাচ্ছি, এমন সময় ডক্টর ওই যে আখতারুজ্জামান পুলক, আমাদের সরকারি হোমিওপ্যাথি কলেজের টিচার, প্লাস উনি হোমিওপ্যাথির এক ভালো পর্যায়ের একজন লিডার বটে, সরকারি চাকরিতে আছেন, সরকারি হোমিওপ্যাথি কলেজের ভাইস প্রিন্সিপালও বটে। আবার আমার আমার কোর্সের ছাত্র আবার উনি। উনি ফোন করলেন। উনি স্কয়ার হাসপাতালে ওনার হার্টের সমস্যা ছিল, চিকিৎসা করে এই বাসায় গেলেন আজকে। তো আমার সাথে আলাপ করেছিলেন যে স্যার এখানে হোমিওপ্যাথিক ওষুধ দেওয়ার কোনো সুযোগ আছে কিনা। তাই বললাম তো সুযোগ তো পুরোপুরি আছে। তো আমি যখন একটা ক্লাসে ঢুকছি, আমি ক্লাসের পরে অথবা কালকে আপনার সাথে আলাপ করে, বা বেটার হবে যদি আপনি আসতে পারেন, না হলে আমি টেলিফোনেই ভিডিও কল করে পুরা হিস্ট্রি নিয়ে ওষুধ দেওয়া যাবে। ওনারটা হলো মূলত যেটাকে বলে স্লিপ অ্যাপনিয়া। স্লিপ অ্যাপনিয়া বুঝলেন তো না, যারা ঘুমাইতে গেলেই শ্বাস বন্ধ হয়ে যায়, গেলেই শ্বাস বন্ধ হয়ে যায়, এবং আপনার পালস কমে যায়, ব্রেডিকার্ডিয়া হয়ে যায়, ব্লাড প্রেশার কমে যায়, মানে ঘুমাইতে গেলেই সব একসাথে ধরে ওনাকে। আমি বললাম যেহেতু এটা একটা ফাংশনাল ডিসঅর্ডার, ওরা অনেক 3 দিনের মতো চেক আপ করছে, যত একেবারে সারা শরীর বলা চলে, ওরা কিছু পায় নাই। তাই বললাম তো এখানে তো হোমিওপ্যাথিক চিকিৎসা দেওয়ার একেবারে মানে ভরপুর অবস্থা একেবারে। এটা একটা ফাংশনাল ডিসঅর্ডার, এবং ওরা যে ক্লিয়ার করতে পারে নাই, আমি তো মনে করি আমাদের ওষুধে ক্লিয়ার হয়ে যাবে। এই এই আলাপ করতে আমার দেরি হয়ে গেল। উনি জাস্ট 9টায় আমি ঢুকবো, 9টায় ফোন করছিল। তো যাক, ওনার জন্য সবাই খুব উদ্বিগ্ন ছিল বটে। ভালো যে উনি ফিরে আসছেন কোনো ধরনের সমস্যা ছাড়াই, কারণ বয়স যখন আপনার 60-এর কাছাকাছি হয়ে যায়, যেমন আমাদের যে বয়স, আমার সামনে আছে বীরেন্দ্র দেবদা, মানে কোন সময় কি হয়ে যাবে, বা এই যে ডাক্তার কেমাল উদ্দিন ভাইও আছেন, মানে ঠিক নাই। এই বয়সে কোনো কিছু হয়তো কালকে শুনলেন যে আমি হাসপাতালে বা কত এরকম চিটপটাং হয়ে গেছি, এটার কোনো নিশ্চয়তা নাই। যাক, আমরা সবাই সবার জন্য দোয়া করি, এবং কেউ একজন বিপদে পড়লে সবাই যেন আমরা এগিয়ে আসি। আমার মনে হয় আমরা শুরু করতে পারি। ডক্টর আনোয়ার পাটোয়ারি,
রেডি আছি, আপনি স্ক্রিন শেয়ারটা দিলে আমরা শুরু করে দেব।
আমি দিচ্ছি, এখনই দিচ্ছি। আজকে শেষ করব, আজকে ইনশাল্লাহ এই লেকচার শেষ হয়ে যাবে, ইংলিশ ভার্সন।
যারা ক্যামেরাগুলোকে অন করে রেখেছেন, আপনাদের কাছে একান্ত অনুরোধ, আপনারা ক্যামেরাগুলো একটু বন্ধ করে দেবেন প্লিজ। আপনার ক্যামেরার কারণে ক্লাসের অন্যদের মনোযোগ নষ্ট হয়। একটু প্লিজ আপনারা চেম্বারে বসে অথবা হচ্ছে ঘুমিয়ে, ঘুমিয়ে তো না, মশারির ভিতরে মশার ভয়ে যেখানে বসেই ক্লাস করেন না কেন, কষ্ট করে যদি ক্যামেরাটা বন্ধ করে দেন, আমাদের কনসেন্ট্রেশন ব্রেক হবে না, এবং যিনি লেকচার দেবেন উনি স্বাচ্ছন্দ্যে লেকচার দিতে পারবেন। একটু প্লিজ এই বিষয়টা একটু খেয়াল রাখবেন।
শুরুতে সবসময় বলা হয়, কিন্তু অনেকেই মানেন না। জানি না ওনাদের কি কানে শোনে না নাকি বুঝি না।
কঠোর বলবেন না কেন, অনেকে বুঝেন না, এটা একটা খেয়াল রাখতে হবে আমাদের। ইচ্ছে করে করেন, আমরা মনে করি না, আসলে বুঝেন না অনেকে।
সেটাই।
জি, আপনি শুরু করুন।
হ্যাঁ, কয়েক সেকেন্ডের মধ্যে আমরা লাইভটা স্টার্ট করে দিয়ে আমরা শুরু করবো স্যার। আউযু বিল্লাহি মিনাশ শাইতানির রাজীম, বিসমিল্লাহির রহমানির রহিম। বাংলাদেশ হোমিওপ্যাথিক পরিষদের পক্ষ থেকে অনলাইন ভিত্তিক উচ্চতর প্রশিক্ষণ ক্লাসে সবাইকে স্বাগত জানাচ্ছি। প্রিয় দর্শক এবং আমাদের গুগল মিটে উপস্থিত প্রিয় ডাক্তার ভাই ও বোনেরা, সবাইকে আন্তরিক শুভেচ্ছা অভিনন্দন। আশা করি সবাই ভালো আছেন আল্লাহর রহমতে। আপনারা জানেন আমরা প্রতি রবিবার এবং বুধবার আমাদের এই অনলাইন ভিত্তিক উচ্চতর প্রশিক্ষণ ক্লাসটি করে থাকি। ধারাবাহিক আলোচনায় আমাদের আলোচনা হচ্ছিল সিকেডি নিয়ে, ক্রনিক কিডনি ডিজিজ বা ক্রনিক রেনাল ফেলার, এই বিষয়টার উপরে আমাদের স্যার আমাদের ইংলিশ ভার্সনে গত 2 সপ্তাহ ধরে আলোচনা করেছেন। আজকেও একই আলোচনা, এবং আশা করছি আজকে 3য় পর্ব এবং শেষ পর্বের আলোচনা হবে। আপনারা প্রত্যেকেই ক্লাসে আপনাদের ক্যামেরাগুলো এবং মাইকগুলোকে মিউট করে দেখে সহযোগিতা করবেন, এবং ক্লাস শেষে আমরা আজকে আশা করি একটি প্রাণবন্ত প্রশ্নোত্তর সেশন হবে। এবং আমাদের স্যার পুরো ক্লাসটি ইংলিশে নেবেন। আমরা যারা ইংলিশে করতে পারি মোস্ট ওয়েলকাম, আপনারা ইংলিশে আপনাদের প্রশ্নগুলো করবেন, অথবা আপনারা আপনাদের ক্লাসটাকে প্রশ্নগুলোকে আপনারা বাংলায় করবেন। আমরা স্যার প্রতিনিয়তই যেটা করেন ইংলিশে উত্তর দেওয়ার চেষ্টা করেন, এবং আগামী সপ্তাহ থেকে ইনশাআল্লাহ আমরা এই ক্লাসটিকেই আবার একই বিষয়ের উপরে বাংলায় প্রেজেন্ট করবো ইনশাআল্লাহ। আর আমাদের কন্টিনিউইং মেডিকেল এডুকেশনের আওতায় আমরা আগেও বলেছি, আবারও মনে করিয়ে দিই, আমরা উপস্থিত যারা আছেন তাদেরকে আমরা হোমিওপ্যাথিক পরিষদের পক্ষ থেকে বছর শেষে আমরা একটি সার্টিফিকেট প্রদান করে উৎসাহ দেওয়ার চেষ্টা করব, এবং এটা শুধু সার্টিফিকেট প্রাপ্তির জন্যই নয়, বরঞ্চ আমাদের ব্যক্তিগত ডেভেলপমেন্টের জন্য অত্যন্ত গুরুত্বপূর্ণ একটি বিষয় বলে আমরা মনে করছি। এই জন্য আপনারা আমাদের সাথে যুক্ত থাকবেন। তো এই পর্যায়ে আলোচনায় আসছেন বাংলাদেশ হোমিওপ্যাথিক পরিষদের সম্মানিত সভাপতি ডক্টর শেখ ফারুক ইলাহি স্যার। আমি স্যারকে বিনীত আমন্ত্রণ জানাচ্ছি তার আলোচনা শুরু করার জন্য। ধন্যবাদ।
বিসমিল্লাহির রহমানির রহিম। Thank you, Dr. Anwar Patwari. Honorable viewers, dear homeopathic colleagues, students, teachers, and practitioners, Assalamu alaikum, good evening, adab. Let us start our long lecture, Chronic Kidney Disease and Renal Failure, Homeopathic Approach. Last 2 weeks, we discussed part 1 and part 2, and I hope today will be the last part, and this will be the most important part of the topic, that is the homeopathic approach to chronic kidney disease. As a homeopathic physician, what should be our approach and what can we do to tackle such big problem? So I'm just showing you my previous slide to help somebody who was maybe not present in other classes, and then I'll start the lecture today. So just I am going through the slides, just you can see. This is anatomy of the kidney we discussed. Then we discussed structure and functions of nephron, which is the functional unit of kidney. This is anatomy of kidney and nephron. This is the structure of a nephron we discussed almost fully in the previous lectures. These are the functions of kidney. We should know the treatment of chronic kidney disease, but we must know beforehand what is the normal functions of kidney. So this is very important. And then we discuss renal failure. Renal failures are of 3 types: acute renal failure, chronic renal failure, and end-stage renal failure. We discussed about acute renal failure almost in details, causes of acute renal failure, clinical features, then management of acute renal failure. Then we discussed about chronic renal failure, its etiology or the causes, then the clinical features, what are the signs symptoms of chronic kidney failure. We discuss the symptoms according to the systems. So almost in details, who were present in the previous class, you know it already. Then very, very important is stages of kidney disease. And how can you make this staging of the kidney disease? Very important. This is very important, and I will say this is little bit complicated to understand. Even a new MBBS doctor, allopathic doctor, also he may not know all this staging fully. So I try to present as easily as possible so that you can understand, and I hope most of you understood this thing. This page is very, very important. Just you can keep it in your stock and try to understand. Now, even anybody A DHMS homeopath, he can make out what is the GFR of his patient. If your patient comes off kidney renal failure and you don't know the GFR, even you can calculate from this formula. You see, we said that chronic kidney disease are of 5 stages: stage 1, stage 2, stage 3A, 3B, stage 4, and stage 5. Stage 1 is the just beginning of chronic kidney disease or failure, and 5 is the total renal failure when the patient needs dialysis or transplantation. Now, how we make this staging? This is on the basis of GFR. If the GFR is more than 90 ml, it is stage 1. If it is 60 to 90, it is stage 2. It is 45 to 60, it is stage 3A. It is 30 to 45, this is stage 3B. It is 15 to 25, 15 to 30, this is stage 4. If it is less than 15, it is stage 5. And it is less than 10, he must start dialysis, otherwise the patient will die, or she or his life will be in jeopardy. So you see, this staging is done mostly on the basis of GFR. Now, how can we make out the GFR of a patient? So you see the formula here. Formula is 140, this is just number, and you minus age of the patient in years. Say if your patient, say my age 67, so you subtract 140, then 67, and you see how much it comes. Then you multiply it by the weight. My weight is 78 kg, so you multiply this one. Then you divide this by 72 and serum creatinine. If my serum creatinine is, say for example, 1.2 and 72, you multiply. And this one, you put below this calculation. And you find the GFR very easily. So anyone, you just measure your own serum creatinine tomorrow from the laboratory, serum creatinine. Then you know your GFR, you see. You know your weight, you know your weight in kg, then you know the GFR. It is so, I made it so easy. So I hope this will help our homeopathic brothers and students to evaluate a patient of chronic kidney disease on the basis of GFR. Then we discussed about management of CRF, means management of chronic renal failure. But this is the modern, or you can say the conventional way of treatment. If there is a patient of chronic kidney disease, the nephrologist will go on this way to manage his case. We discussed already, that's why I am not going in details. They try to make something to control the progress of kidney disease. Maybe the patient came in the stage 3. Now the nephrologist will try to retard its progress towards stage 4 and 5. How? So he will control the blood pressure. Blood pressure must be controlled. If he has diabetes, it must be controlled. Otherwise, you cannot regress its progress. Then his lipid level, cholesterol, triglyceride, must be lowered. Then his electrolytes, if he has more potassium, more sodium, or less sodium, you will have to take care so that his electrolyte level becomes normal. Then fluid. You cannot allow patient to take fluid, to take water as he likes. No. You may give him only 1.5 liter to take for 24 hours, and you restrict his fluid taking. Then you treat his anemia, because all patients of chronic renal failure must suffer from anemia. So you will have to take care to treat his anemia. Then osteodystrophy, because most of the patients, you know, they have bone disease. They have less calcium in the blood. So they lose calcium from their bone, and their bone becomes diseased. Bones become friable. So you'll have to take care. But you see, at the end, the nephrologist can retard the progress of chronic renal failure maybe for few years, maybe 2 years, maybe 5 years, but ultimately the patient will go to complete renal failure, which is called ESRF, end stage renal failure. His GFR will be less than 10, less than 5. And if he does not go on dialysis or peritoneal dialysis, patient will, it is sure that he is going to die. Because one cannot live without functioning of his kidney. And after the dialysis going on, the patient will search for a transplant, either from a live donor from his relative or from a cadaver. One person of brain death, maybe he will donate the kidney and he can take the kidney in his body by operation and then he will live. So we discussed about hemodialysis, we discussed about peritoneal dialysis. This is the hemodialysis we discussed other days, so I am not going to say the details. This is arteriovenous fistula. A patient of chronic renal failure on dialysis, he must have one arteriovenous fistula. We discussed the other day. And that was, I showed you, I work in hemodialysis unit as, I was the chief of hemodialysis unit in a hospital in Saudi Arab in 1986. So this is almost 37 years before. This is myself, and I was just working in this unit. They were my staff. And I also showed you the peritoneal dialysis. If a person cannot afford hemodialysis or if it is not available in his city, then what to do? Should he die? No. He can undergo peritoneal dialysis like this. We discussed also. And after all this dialysis, he must prepare himself to get a new kidney to be transplanted in his body. And also we discussed that many people have a wrong idea that patient of kidney failure must have removal of kidney and then to add new kidney in its place. No. His kidney will be kept in the same place here, same kidney place, this disease kidney. But he will have the new kidney here in the pelvis, connected with the common iliac artery, you see here. So he will have 3 kidney, 2 unfunctional kidney and 1 new functioning kidney from the donor. Now, let us come to the lecture of today. This is homeopathic approach to management of chronic kidney disease. This is very, very important, and I hope those who will attend the lecture today, sure they will have some good idea about homeopathic view of chronic kidney disease and renal failure. And this will help him how to manage patient when it is recoverable. And also he can manage the patient by giving palliative treatment when it is not curable and he must go for dialysis or something like this. But he can help the patient by giving him symptomatic remedies. So, first of all, we must know the etiology, homeopathic etiology and pathogenesis of chronic kidney disease. One will say, why you are saying etiology and pathogenesis? These are not allowed in homeopathy. No, this is allowed, of course. Etiology means cause, knowledge of cause. As homeopathic physician, we know the cause of disease, and we also know the cause of acute disease, chronic disease. And so we know the causes of chronic kidney disease from homeopathic point of view. And also we know the pathogenesis. Homeopathic pathogenesis means miasmatic pathogenesis of chronic kidney disease. How a kidney disease starts, then how it progresses to ultimate failure, and which miasm it will bear on its journey from beginning to end. So if we can understand this thing, it will help us managing our patient by homeopathic remedies. Just only 2 pages here, I can read out and also you can understand. I said CKD. CKD means chronic kidney disease is a chronic syndrome. This is not an acute disease. This is a manifestation of chronic disease according to homeopathy. Since it is characterized by gradual progression, its progression is gradual, not very fast, and it's multifactorial in nature, and it has many sorts of symptoms, many sorts of its pathology. Considering the end-stage renal disease, it is essentially psychosyphilitic in nature. Considering the nature of symptoms, you see, it is saying when the patient attains the end-stage renal disease, if the nature of the disease becomes psychosyphilitic, we will discuss just little afterwards. It becomes psychosyphilitic in nature. Considering the nature of symptom, we will have to know what are the symptoms of SORA, what are the symptoms of psychosis, and what are the symptoms of syphilis. Then only we understand the symptomatology of any chronic disease. However, the developmental stages of renal failure involves different pathological changes, and this change will decide the miasmatic preponderance at that stage. Because you don't know in which stage the patient will come to you. He may come in the stage 1, or he may come in the stage 5, or maybe he may come in between in the stage 2 or 3. You don't know in which stage. But as soon as the patient comes to you, you should try to know the stages of his disease he is in, as we classified before. This will help you to think that his disease is still recoverable or not recoverable. This is a very important idea. If it is recoverable, okay, you treat him by constitutional medicine, by deeper acting medicine, and try to make the progress of his cure according to Hering's law of cure. But if the patient comes in stage 5, so you know that it is not recoverable, and maybe he's very soon he's going to start dialysis, otherwise his life will be jeopardized. Then what to do? Then if the patient still insists that he will never do dialysis, or maybe he will die, patient say like this, that I will rather die, but still I have not started dialysis. So in that patient, still you can help him. But by giving palliative treatment, you should not treat him that time by deeper acting constitutional medicine, then you will harm the patient. You will have to treat him by superficially acting, shorter acting medicine first. And only if you think that his case is progressing, because some case we find that even in advanced stage, by giving homeopathic medicine, his condition progress. His creatinine was, say, for example, say 6 or 7 maybe. It came to 5, then it came to 3. If it happens something like this, then you say, thanks God, and you can treat him accordingly. Then you can go for deeper acting medicine. But if you find that his condition is not responding well to your medicine, well selected medicine, then you know that his case is incurable, and don't try to give him deeper acting constitutional medicine. Rather, you try to treat his condition symptomatically by giving superficially acting or shorter acting medicines. So we see miasmatic interpretation of chronic kidney disease. CKD, chronic kidney disease, is a product of trimiasmatic chronic disease. You see, this is not produced by a single miasm, as Hahnemann also said, and the homeopathic stalwart after Hahnemann, say before 50 years, say for example, Dr. Allen, J.H. Allen, and then other doctors, I will say afterwards, who were researching with kidney miasmatic progression, miasmatic pathogenesis, and miasmatic symptomatology. They also said that nowadays you don't find a chronic disease simply arising from SORA. Almost always you find that it has been complicated by 2 or 3 chronic miasms, not it is coming singly. So also our chronic kidney disease, it is a trimiasmatic chronic disease. It has involved all 3 miasms. How? We'll say. It has a cyclic base. Why cyclic base? You see, as the kidneys develop from the intermediate mesoderm layer of the germinal plate. What does it mean? I think I discussed in an early lecture on chronic disease that our embryo in the womb of our mother develops from a germinal plate. The brood first forms a germinal plate. This germinal plate develops into the fetus afterwards. And this plate has 3 layers. The outer one is ectoderm, middle one is mesoderm, and the innermost is endoderm. So we know that mesoderm, the middle layer, usually gives rise to cytotic diseases more. And the ectoderm, the superficial one, mostly give rise to psoriatic diseases. And the endoderm, the innermost one, most likely give rise to most of syphilitic chronic diseases. So as kidney develops from intermediate mesodermal layer, so it has a base to become cytotic, because this plate has predilection to be affected by psychosis more. And early nephrons develop from primary mesenchymal cell, and this nephron also develop from these mesodermal cells. So we can think that kidney diseases mostly originate or develop into cytotic base and cytotic proliferation. But as the disease progresses, it reveals its syphilitic miasmatic nature. But when the disease progresses, then it will destroy more of nephrons and nephrons. There were 2 million nephrons in the beginning. Now it will destroy lakhs and lakhs of nephron. Maybe ultimately only 5 lakh nephron or maybe 1 lakh nephron remaining, and all other destroyed. So it reveals its syphilitic nature at the advanced stage of kidney diseases, leading the patient to gradual decline, ending in renal failure, and ultimately the patient develops renal failure. It is killing the kidney, which threatens the patient's life unless it is maintained by dialysis or kidney transplantation. So though it started from a cytotic miasmatic base, but when it progresses and it destroys the kidney, progresses and destroys the kidney. And its nature becomes changed into syphilitic nature, and its symptoms become syphilitic in nature. And ultimately, there will be renal failure and patient will die unless his life is maintained by dialysis and kidney transplantation. In the beginning of CKD, before deeper pathology affects the kidneys, its symptoms picture appears to have psoriatic taint, and we'll see. Though its base was developed from cytotic base, but its symptoms, and it has some ramifications which gives assumption of psoriatic taint. How? Now we will discuss the progression of CKD in 3 miasms nature. How and when we say, yes, this has psoriatic taint, psoriatic domination, and you can use more psoriatic antipsoriatic remedies. And by its symptoms, by its progression, we can know that, yes, now it has attained the psychotic dominance, and we'll have to give him antipsychotic medicines. And by its symptoms of progress, we will know that now it has attained the syphilitic dominance, and that time it is destroying everything, and it is going to destroy the life of the patient. It has syphilitic nature, and then you select medicine which are more prone to develop antisyphilitic nature, antisyphilitic medicines. So what is the soric features? One is involuntary urination due to sneezing. Some patient will say, those who have weakness of the renal system, they will develop enuresis. They cannot retain urine. If he is sneezing, laughing, coughing, he will pass urine involuntarily. Or maybe he cannot check his urging of urine. He has urging, he must run to the toilet, otherwise he will soil his clothes. And urine will be colorless, pale, and copious. And there will be recurrent urinary tract infection. Patient will say, oh, I have burning of my urination, and there is tangary. I pass only little urine, but with much urging. So this sort of painful symptoms, dysuria, will develop much. And he may have retention of urine when he will be exposed to cold weather or fright. There may be hematuria or chyluria. This sort of symptoms, if prominent in a kidney disease patient, it indicates that this stage the patient is showing soric taint, soric dominance. And that time it is better to try to select antisoric remedies, giving emphasis on these symptoms. Then when the stage will progress more, you will find the patient has developed hypertension. Before his blood pressure was okay, but now he has high blood pressure. He has atherosclerosis of blood vessels. They have fat deposition inside the blood vessels and making the blood vessels narrow bowed, and it will lead to high blood pressure. The thickening of glomerular basement membrane, this is filtering membrane. This will be thickening of the basement membrane. So filtration will be less. So this thickening, then excessive fat deposition. He has more lipid deposition in various tissues. These are psychotic symptoms, psychotic trends. Then hypertrophy of the organs. His kidney will be bigger. His kidney will be hypertrophied, you see. It will go to atrophy afterward, but this stage, if you take an ultrasonography, he has diabetes and he has blood pressure, and you see his kidneys are bigger. So these are all psychotic trends. Then accumulation of fluid in the body. He will have edema in the body. He will have obesity. He will have myeloid hyperplasia, gouty kidney. He will have gouty kidney. Why? Because kidney is not working well. That's why kidney cannot pass creatinine, uric acid like this, and there will be hyperuricemia. And if your uric acid, blood has more uric acid, then you will develop gout, painful joint condition. So these are all psychotic trends. There may be stricture of urethra, renal dropsy in the case of nephrotic syndrome. So by this, you see, by the nature of these symptoms, it gives you the idea that the patient is now having psychotic dominant features. So you should select for this condition mostly medicine having more antipsychotic nature. This is the direction of Samuel Hahnemann to treat chronic disease. You will have to consider the miasmatic dominance from the symptomatology. He said that all the miasm are not dominant at the same time. You find one is dominant and others are little bit dormant. So that time you give the medicine of dominating miasm. So if it is psychosis, you try to give him antipsychotic remedies. Now, patient may come to you in the later stage This stage will not stay a long time. This stage will progress to glomerulosclerosis. The kidney structure will be sclerosed. There will be fibrosis. Kidney tissue will be fibrosed, destroyed. And chronic renal failure with destruction or loss of nephrons. And his nephrons will be lost and lost. Maybe it was 2 million nephrons. Now he will lose, say, more than 16 million nephrons. So you find complete atrophy of the kidney. If you take an ultrasound of the abdomen, KUB, you find there are atrophy of both kidney and destructive changes in other vital organs. And secondary hypertension and malignant hypertension. Maybe his hypertension will be more even to malignant hypertension. You know, malignant hypertension we already discussed while we discussed hypertension. So these are all syphilitic nature of the chronic kidney disease. So if you find these things, you will have to think that this patient now in a stage where there is syphilitic features are dominating. So according to Hahnemann, you will have to select your medicine this stage having mostly anti-syphilitic features. Then you will do justice to the treatment of this case. The syphilitic nature of the kidney failure is revealed by the permanent structural destruction of the nephrons. You will find that his kidney nephrons are permanently destroyed. Thus, kidneys become unable to maintain the body's homeostasis. And kidney in such condition, in such widespread loss of nephrons, kidney is unable to maintain the homeostasis, the balance of the vital function of the body. And the patient will die unless maintained by dialysis or transplantation. So, if we can, I tell you, you don't find this thing in books. Only if you know chronic disease well, you know the symptoms of chronic disease well, and you know the various symptoms of 3 stages of chronic kidney disease, then you can classify the symptoms with miasmatic staging. So somebody may give better picture than myself, but this is a good base for a mediocre student or practitioner to think upon the nature of homeopathic miasmatic nature of chronic kidney disease, and he may be in a good position to treat his patient in a better way. Now, this is a good thing, this is a good idea to treat a complicated disease by homeopathic medicine. Okay, we know how to treat a patient by homeopathic medicine. We know it. That Hahnemann said you will have to take a good history from the patient according to Organon 83 to 104, details history. Then you sort out the symptoms, giving importance to the rare, uncommon, peculiar symptoms following aphorism 153, and you make an anamnesis and you try to find out a medicine from our materia medica who has most similarity to this symptom group. This totality of symptoms what we made, now it is my duty as a homeopathic physician to find out from the materia medica, out of hundreds of medicine, one medicine who has most symptoms similar to this group. This one you can do by your mind, by your study, by your wide knowledge, but a mediocre homeopath like us, we also take, if the picture is very clear and points to a medicine, say it is very clear, it is pointing towards causticum, okay? It is pointed towards plumber metallicum, it's okay. It is pointed towards acid force, okay. I'll not go to other way. But sometimes we find that the symptoms do not point to a medicine very clear cut. It is giving picture of 2-3 medicine, partial pictures. It does not give a picture of a single medicine. So what to do? You cannot refuse to your supposition, no, your conjecture, no. So there is a scientific way how to find out a most similar homeopathic remedies. So we go for repertorization, and with sensible mind, not going to do repertorization just like anything. That must be a very intelligent way of repertorization. What is intelligent way? You will have to select what symptoms represent the disease or the disease condition of the patient. What are the actual symptoms? What are the symptoms of the patient? It is representing more to the patient, less to the disease. And this sort of symptoms you give importance and try to find out medicine by taking out the rubric of such symptoms, giving more importance. Then you may find the most probable simillimum for this case, because there is no other way. Either from your vast knowledge of mathematica, if you can find out the medicine picture, it's okay. But if you don't find what to do, you will have to go to repertorization. Before, say about 30 years, we used to do repertory mostly from Kent repertory, 6th American edition. Mostly we used to take the help, and maybe Fatok's repertory, Borik's repertory, Burning Ocean Therapeutic Pocket Book or Burning Ocean repertory. These were our 5-6 repertory we were using. But nowadays there are so many repertories. You can take help of many symptoms from many repertories, and you can also justify them. You can also compare them. You can analyze them, and this will help you if you have a good mind and your homeopathic thinking. You can find out a most simillimum homeopathic remedy for this condition. But for this thing to do, you must be familiar with the rubrics available in the repertory pointing to chronic kidney disease. You should know that what are the rubrics here available which point to chronic kidney disease. If you don't know, you never searched repertory for kidney symptoms or urinary symptoms or something like this, then you are not an expert to find out all the good rubrics representing the symptoms of your patient. That's why I did some work or workup for you. So I searched out, there are hundreds of symptoms of chronic kidney disease in the repertory. Hundreds of, not 100. But I kept here little more than 100 for you, the most common one. There are other symptoms also. So I advise our homeopathic practitioners, particularly those who are young, and if you are very old and you don't know, also for you also the same advice, that you go through a repertory and familiarize yourself with the rubrics available in various repertories. Then you can take good help of repertory to find out or to help you find out a good simillimum. Okay, so let us go here. So I took here 104 symptoms. There are many other symptoms, but I have chosen or sorted out 104 for you. These are the symptoms or the rubrics in the repertory regarding kidney failure and chronic kidney disease. Some we can utter here. Say if you go to the kidney chapter, you find renal failure. You find renal failure acute. You find renal failure chronic. You see, you don't give medicine by this rubric. You never give. because these are not good symptoms. These are pathology. But why you should study this thing also? Because this will give an idea. There are some, say, 15 or 20 medicine in the rubric here, maybe from chronic kidney failure. It will give you some idea about the nature of medicines who have pictures of chronic kidney disease. So you don't give him medicine by this rubric, but if you study this one, it will enrich your knowledge to deal with kidney disease with a similimum. Then you go here, coma, renal failure with. A patient may have comatose. He can go unconscious with renal failure. Also, we have symptoms here, you see. Then there is uremia. The patient has more creatinine and urea, they develop, it is called uremia stage. And by uremia, he will go to uremic coma. He will be unconscious and he will die before reaching the hospital. So, also it is giving you some idea what are the remedies, maybe possible remedies which can develop into uremia. Then you can go to general, you find dropsy, external dropsy, kidney disease from. You will find in a patient of chronic kidney disease, fluid retention. Now I ask those who are junior doctors, I tell you, you may find edema mostly around the end of the eye, you see. The kidney disease edema mostly develops, in the beginning it develops around the eye. And edema of heart disease, it develops mostly in the ankle. So for a disease of patient of kidney disease, we search around the eye if he has edema. So you see there is a rubric, external dropsy kidney disease form. There are rubric, dropsy liver disease form, dropsy heart disease form. So you find from kidney disease form there are separate group of medicine, and you may have some good idea about what are the medicine developing this condition. As I said you, there may be edema around the eye. There may be in the face. We say puffiness of the face, and you will find here rubric also. Or he may have edema in the chest. He may have pleural effusion, hydrothorax, and the patient will have difficulty in respiration. He may have edema in his abdomen. We say this is ascites. He may have edema in his scrotum and in the legs, like this. And if you find edema all over the body, we say this is anasarca. And also you find rubric of anasarca. So if you study the materia medica as well as repertorial rubrics, more and more, you will have in your mind the picture of many medicines which have symptoms like a patient of chronic kidney diseases. And this will help you to select his medicine better than others who are not initiated with such practice or with such exercise. Then you find dropsy, external dropsy with albuminuria. You find most of the kidney patient, chronic kidney disease patient, they have albumin passing through the urine. You find urine examination, routine test, there will be 3+ albumin. This is called albuminuria. And also you have the idea which medicine, there are 7 medicine who have albuminuria with external dropsy. Then you find nephrotic syndrome. And in the kidney you find glomeruloproliferative, it is called glomerulonephritis. We know kidney failure develops mainly from 3 groups of diseases. One is diabetes, one is hypertension, and third is kidney diseases. Diseases involving mostly kidney, and this is called glomerulonephritis. Chronic glomerulonephritis, nephrotic syndrome, something like this. So you find what are the medicine can produce symptoms like glomerulonephritis as well. So you find nephrotic syndrome, glomerulonephritis, then you find, you see, kidney inflammation accompanied by uremia, kidney inflammation accompanied by difficult respiration. If you find a patient with chronic disease having dyspnea, difficult respiration, there is a rubric. And if you find chronic inflammation of the kidney, chronic nephritis, there is a rubric. Then you find chronic interstitial nephritis, acute parenchymal nephritis, suppurative nephritis, kidney atrophy. You find that by ultrasonography, patient kidney has atrophy. Also you have rubric. Then complaints of kidneys accompanied by hypertension. You may find chronic kidney disease symptoms with hypertension. There are rubrics. Then you may find he has high creatinine, maybe creatinine 7. Also, you see, you have a rubric here. No, I don't say you give medicine from this rubric. No, it is giving an idea there, because when it was proved, our medicine was proved on not on laboratory basis, on mental symptoms, general symptoms, what the patient can narrate. These were the symptoms. But later on, many clinical symptoms came, and these symptoms was given by Dr. J.T. Kent, Dr. Boric, and so many doctors. And these are allowed. This is called clinical symptoms. This gives an idea about the nature of the medicine or nature of the pathology this medicine can produce in a prover. So you see, there is also medicine which has high creatinine. Then hydronephrosis. Kidney has hydronephrosis. Urine, you find many things, albuminous urine. Then kidney, so many rubrics you see here. Just I give you some idea only. Then you find pain around the kidney. There may be pain in the kidney. Pain has extension downwards, extension towards the thigh, extended towards ureters, maybe genitalia. Sometimes, kidney failure occurs by bilateral kidney stone, bilateral nephrolithiasis, and they give rise to bilateral hydronephrosis, giving rise to atrophy of the kidney. So if you have such rubrics here also, you may find there is pain in the kidney with a stone, and it is extending towards thigh, it is extending towards penis, it is extending towards ureters like this. Then you find kidney pain, maybe after urination ameliorate. People, person, I have pain here in my right kidney. After I pass urine, it ameliorates. Okay, this is a good symptom. And patient may say that I have pain in the kidney if I delay passing urine, that I have urge of urine, but I am not going for something. This delay is causing my pain in my kidney. Also, you see, this is a rubric. Kidney pain, urination delayed if desired to urinate is. Then kidney pain when urging to urinate. Then you find polycystic disease of kidney even. You see, these are all clinical symptoms, but this gives an idea of some medicine which can produce this even in the level of polycystic disease of kidney. And we know in the etiology of the kidney disease, chronic kidney disease, that polycystic disease of kidney is one of the cause. What is polycystic kidney disease? It means kidney has congenitally from his birth so many small cysts all over the kidney, in both kidney. This is called bilateral polycystic disease of the kidney. And if a person has this polycystic disease of kidney, he may live up to say about 30 years, maybe 50 years, maybe 60 years, and ultimately he will develop chronic renal failure, because this cyst will destroy gradually his kidney tissues, his nephrons. I told you in my in previous lectures, one of our homeopathic board official, big official, he died may Allah give him heaven as an abode. He had chronic kidney disease due to polycystic disease of kidney. And once upon a time, he came to me also to help him searching a medicine, because he was a good homeopath. He was himself was a good homeopath. He was a vice principal of a homeopathic college, and later on he became the big official of the board. And he retired. He went abroad and he died of this thing. So I know from him. Sometimes he was contacting with me that my condition is this, my condition is that. So that was from, I told him that you have polycystic disease of kidney. It is mostly incurable in your stage because his creatinine was so high. I told him only you can delay or you can palliate your condition. Maybe this is not possible to cure it. And we gave him medicine. In that way, he was following such medicines. So even you see, in previous repertories you don't find such rubric, but here also you find such rubrics, and this gives an idea about some medicine that they can even develop polycystic kidney if acted long on the kidney. Then stones in the kidney, then kidney suppression of urine, then kidney swelling. You find in the ultrasonography there is hypertrophy of the kidney swelled. There is uric acid increased, urination after ml, kidney complaint after urination ameliorate. You find this thing. Then patient may say, I have heat in the region of kidney. I have heat. I have pain in the region of kidney. Patient may have parenchymatous inflammation of the kidney accompanied by, say, albuminuria. Patient may have parenchymatous inflammation of the kidney. Patient may have inflammation of the kidney and pelvis. Patient may have urine having cast, hyaline cast. You see, when a patient has glomerulonephritis, chronic glomerulonephritis, we ask the test of urine for RE, and in the RE we find there is hyaline cast. You should know. Hyaline cast means his glomerulus are affected, and you may find hyaline cast, granular cast, epithelial cast, and you see these are also in our rubric. We did not have this rubric before, but afterwards many homeopathic stalwarts, they were adding these clinical symptoms and rubrics in the repertory, and thus they are increasing our idea about the disease pathology. You find urine is cloudy, urine is copious, so much urine. Urine is milky, it is like white. Urine is scanty, urine has sediment, and it has clay colored sediment, it has bloody sediment, it has red sediment, it has white sediment. You may find a patient having both renal colic in both kidney, and he had stone in both kidney, and he passes white stones or white sands in his urine. You may find, and we have medicine with these symptoms. You know what medicine. And we may find that patient have sands red color. He has right-sided renal colic, or maybe he has a stone there, and he is passing urine with red color sands, and we have medicines. So, if you study the repertory along with Materia Medica, your idea about chronic kidney disease symptomatology with its medicines sure will enlarge, will be bigger. And urine has so many symptoms, you see here. So many urine symptoms. Then you find urination dribbling. Patients say, after passing urine, my urine dribbles. Yes, there is symptom. Patient may say dysuria. That whenever I go to urine, there is painful urine, painful micturition, painful scanty micturition. This is called dysuria. And we have in the repertoire, in the maternity, we get these symptoms. If you find, say, acantharis, you find the dysuria, painful scanty micturition, painful and recurrent, repeated micturition. So we have symptoms here, you see. Then urination interrupted. He will say, when I pass urine, it does not go like a forceful urine. No, it goes with feeble stream, or it is interrupted. It goes, then it stops. It goes, then it stops. So if the patient has such symptom, you have rubric and you have medicines. Urination incomplete. Patient will say, when I pass urine, I think that there is some urine remaining in my bladder. Even if you examine him, ultrasonography of the KUB, they will say that there is, this is called PVR, post-voidal residue. You find when you write USG ultrasonography for KUB, kidney urinary bladder, they will write about the kidney, about the bladder, about the prostate, and they will also write PVR, post-voidal urine, how residue. They ask the patient to come taking too much water. Then they will take the ultrasonography with full bladder. Then they will say, okay, you go to the bathroom and pass urine, then come back. And you pass urine totally, as much as you can. So patient will try, he will cough and he will strain to pass all urine, then he will come back. If he has good urinary bladder and normal prostate, they will find there is no PVR or very few, maybe 5 cc or 10 cc. But if his bladder is not strong enough, or he has a prostate, or there is some visible bowel, urinary bladder outlet obstruction, something like this, then you find even after passing urine, he will have too much urine left in his bladder. This is called post-voidal residue. And what is the significance? You see, if you have if you have too much PVR, it means you cannot expel enough urine from your bladder, and the old urine still remaining in the bladder, and this will give rise to infection in the urine, and you will have recurrent urinary tract infection, and this recurrent urinary tract infection will lead to pyelonephritis, then chronic pyelonephritis, and this will kill your kidney. This will make chronic kidney disease. So we have all the symptoms here. See, so many symptoms. I kept here only 104. So I advise you, don't think that this is the allopathic way of thinking treatment of disease. No, not at all. We'll treat the patient as Hahnemann said. We'll take the history as much as possible. We'll make an anamnesis. We'll sort out the symptom. We'll make a totality of symptoms representing mental symptoms, general symptoms, and important particular symptoms. And then we'll find a single medicine. Maybe we find sometimes there are 2-3 medicine coming in the total picture, but still you cannot give 2-3 medicine together. What Hahnemann said, yes, if the picture is like this, you try to select the medicine which covers more of the symptomatology. So you give this one. Maybe this will not be 100% similimum, partial similimum, Hahnemann said, but you give it. Then you find it will cure some symptoms, and maybe it will bring 1 or 2 more symptoms. Then you take the history again. You evaluate the symptomatology and find another medicine which covers more and more, like this. So this is the way you treat a chronic patient when you find that there are picture of more than one medicines. But we never give all these 2-3 together. No, this is not the way of homeopathy. This is the mongrel homeopathy. But you should develop your ideas more. Developing your symptomatology idea, rubrics idea, even the patient's disease condition idea, which treat him curatively or only you will give him palliative medicine. You should know also the pathology, otherwise you cannot decide. Ken said, don't try to cure a patient who is incurable. This is wrong. When it is incurable, don't try to cure him, you will harm him. Then you give him palliative treatment. Now this is the finishing of rubrics. Now I give you one little bit analysis with all these symptoms, with all these rubrics, 104 rubrics I showed you. When you analyze, maybe before I started doing repertory in 1980s, from 1979 I do repertory. So in the early 80s, I purchased the radar computer program in 1988 from Belgium, direct. Before that, I was doing repertorization manually, analog method. And that was very hard time for us. So if this 104 symptoms to do the repertorization, it would take maybe some hours to find out the most common medicine which covers most symptoms of this 104. But now by computer program, within seconds, we can analyze and find out the most common remedies which can cover most of the symptoms. So by Kentian method, you see these are the medicines: Lycopodium, Cantharis, Barberries, Apis, Phosphorus, Terebinthina, arsenic, album, marcor, nitric acid, phosphoric acid, sarsaparilla, Plumma metallicum, Sevia chelicarp. You see, these are the medicine which covers most of the symptoms of this 104. So this is not giving you the list that you should treat your patient from this list. No, this only gives you an idea that these medicine have so many symptoms of chronic kidney disease in their symptomatology. You may have another medicine not belonging to this list, you give that one. But this is giving you an idea that this medicine have most symptoms of this chronic kidney disease. If it falls in this group, okay. If not, take from otherwise. Now there are another way by Vitolkas expert system. I will not George Vitolkas. George Vitolkas was the mastermind. We say that Kent, we say that Herring, if Herring did not give homeopathic system of medicine anything except only the Materia Medica of Lachesis, his name would have been immortalized lastingly throughout the homeopathic history. It is said like this. Herring যদি লেকেসিস ছাড়া আর কোনো কিছু হোমিওপ্যাথিতে না দিয়ে যেতেন, তবুও তার নাম হোমিওপ্যাথির ইতিহাসে চিরোত্তরে অবিস্মরণীয় হয়ে থাকিত। Same thing, it is said for Kent, that if Kent did not give anything to the homeopathic literature or homeopathic science, but only the repertory, Kent's repertory, his name would have been immortalized in the history of homeopathy throughout ages. And regarding Vitolkas, it is said that this guy, you see, he is an engineer, he is not even a doctor. But he has, in the homeopathic history, not much, very few. There were, before Vitolkas also, in the history of homeopathy, that some people were not doctors, not medical doctors, but they were big homeopaths. And even they were ratified, endorsed by Hahnemann, like Dr. von Boninguschen, Dr. Van Gersdorf, very big homeopath. So what is the contribution of George Vitolkas? We accept it. We appreciate him. Though he is not a medical doctor, no problem. So he has given this radar repertory, and there is a homeopathic. This is called homeopathic materia medica. This radar repertory, you see, it was developed in the university because I purchased it in 1988, but 1,000 US dollar that time. And that time it was not a disk. They gave me 32 small floppy disks. And this floppy disk, when they said, I don't know how to install. And it took 6 months to find some engineer so that he can install and he can train me in working with this, because Archibald told me that you come to Belgium that time in 1988. You come to Belgium, stay with us for 15 days, we'll train you. But that time it was not possible for me to go to Belgium. But I want to say, because I know the history, that time the University of Namur of Belgium, they developed a project and they put Vitulkas as the head of this project. And they consisted 200 homeopathic experts and computer software experts, 200 people, headed by Vitulkas. And they developed this radar bit by bit by 10 years. It is like Taj Mahal of Samrat Shah Jahan. You see, 22,000 laborers, what for, I don't know how many years, maybe 10 years, and they built that Taj Mahal. It is something like this. Radar was developed by a team of 200 computer experts and homeopathic experts, headed by Dr. Vitulkas, for 10 years. And they developed this system bit by bit. And 1988, they put it to the homeopathic world. And Alhamdulillah, I was one of the first ones who bought this one. So, so there is one more, this is called Vitulkas expert system, like Kantian method. So by Vitulkas expert system, if you analyze, it comes barberries, phosphorus, terebinthina, cantharis, apis, Plumber metallicum, epocyanum, arsenic album, marcor, benzoic acid, lycopodium, colchicum, medorinum. You see, almost same. Maybe some medicine here more, some medicine there more. It is something like this. So ultimately, I will ask you who are getting patients of chronic kidney disease often, because Alhamdulillah, I get many patients of chronic kidney disease, and sure many of our homeopathic colleagues also, they get many patients. So if you have more patients, you must develop your knowledge on the symptomatology, on the materia medica, and on the repertory regarding this chronic kidney disease symptomatology, I will say. And you try to develop your knowledge on such medicine more. Apis, epocyanum, arsenic album, barberries, sarsaparilla, cantharis, arsenic album, colchicum, lycopodium, phosphorus, acid phos, acid nitric, acid benzoic, plumbum metallicum, marcor, sepia, calicarb, medorinum, thusa. There may be more, but this will give you a good base, good foundation. Now, I cannot take the responsibility to give you a materia medica study of all these medicines to develop your idea of symptom pictures of chronic kidney disease. But I give you only some sample to study it. It is not possible to give you a list of medicine which you will use only to treat your chronic kidney disease patient. I told you before that you can choose any medicine which come by the symptom of patients. You should not lead the symptom. Symptom will lead you to select the similimum. So any medicine can come, but sometimes some medicine comes often. It is our experience. Say when a patient of chronic kidney disease comes, then and then usually we don't give him his constitutional medicine. No. It is not the way. It is said you see his painful conditions and his painful disease background and give him little bit shorter acting medicine to put him in a suitable stage from where you can start constitutional treatment. But also, if the patient comes in little bit early stage, and if you find a complete picture of constitutional disease, yes, you can give. But for later stage, you should not. If it comes in later stage, advanced stage, you should not, as I said before, the constitutional miasmatic medicine in the beginning. No. So if a patient comes maybe with so much edema, he has no urine, only little urine only, no thirst or maybe more thirst, something like this, and he is having vertigo, cannot sleep, he has appetite, loss of appetite, all these things. These are the superficial symptoms of the deeper pathology. So we select some medicines like Apis mellifica. You will find often you need Apis mellifica. I just show you some picture first. You may find Apocyanum. You may not find. You may find Apocyanum picture superficially. He will come with edema. He will come. In this case, he may have more urine. Some patient has more urine. Some patient has less urine. Some patient has no thirst. Some patient has more thirst. So this Apocyanum has more thirst and more urination, not less, more urination. And it is chilly patient and it has edema. But if you see in Apis mellifica, you find a little bit opposite. This patient will be very hot patient, Goram Katur patient. And he may have no thirst at all, thirstless. He may have no urine at all or very little only. This is oliguria, maybe anuria. And he may have too much edema and he has burning pain in the urine, burning pain in the body. So you see, it is almost opposite to Apocyanum. So you go on considering the symptoms here. I give you some symptoms here only because you will have the lecture. You can study afterwards and you find a good picture. This is workable picture of Apis mellifica I gave you. And this is a workable picture of Apocyanum when sometimes it comes as a first precision to our chronic kidney disease patient. You may have even China. China comes with edema, he has so much weakness and he has flatulence. And sometimes we give China. Sometimes we give Lycopodium. Usually we don't give Lycopodium in the beginning. You see, even for Lycopodium, not for chronic disease, kidney disease, even for other chronic disease, there is a saying. You should not give or should not prescribe Lycopodium for a chronic case in the beginning unless you are 100% sure. If you are very sure that this is Lycopodium, okay, you give. But if you have little bit confusion, it may be Lycopodium or may not, then don't give Lycopodium first. It is said that this will disturb your case if you give Lycopodium which is not well selected. So you give other similar or shorter acting or superficial medicine, and then second time you think that the symptomatology and you are sure that it is Lycopodium, then give Lycopodium. So it is said that in the beginning you should not give Lycopodium unless you are very sure of its simillimum. So Lycopodium also many times it comes in chronic kidney disease. In my patient, I find many times Lycopodium came and Lycopodium helped the patient too much. But you must know Lycopodium totally as much as possible so that you know where it is simillimum to this disease of this patient of chronic kidney disease. You must have very good idea about Lycopodium. There are many, but I don't have time today to discuss details. Otherwise, I think you would enjoy if I discuss. But I just show you to have an idea. Acid force, yes. In many patients, I have acid force for chronic kidney disease patient. But as I said, you must have acid force symptoms for the patient. Then only you give acid force to this patient. But acid force covers, because this is anti-stability medicine. Phosphorus, acid force are anti-stability medicine. So a case comes little bit advanced, and if you find the symptoms of acid force, acid force is a very weak patient, very debility patient, and it is very easy to find out their constitution. They are like phosphorus, they grow rapidly, and they are tall, and they are mentally, physically, they are weak. They are physically weak, and also it takes their mental symptoms, are mentally weak, physically and mentally. They have flatulence, they have sometimes diabetes, diabetes with kidney disease. And if your symptom picture becomes similar with acid force, you find it helps the patient too much. And so it is a very good medicine, and I think if you learn it more, it will help you treat your patient better. We know, that in phosphorus, actually, in acid force, the patients are mentally sick much. Mentally, they're weak. And this mental weakness, he has no urge to do something, to expect something. And this mental apathy, this mental weariness leads to physical weakness. Then he becomes physical so weak. When he has mental weakness first, then physical weakness, and he has feature of tall and weak body, he had a history of sexual excesses, and he has disappointed affection, and he has some urine symptoms, very peculiar urine symptoms. Urine will be white, milky color, and there will be cloud at the bottom of the urine, and he may have diabetes mellitus. And they are like CPR patients, they are very much apathetic, indifferent. They don't have any urge for life. He always think of his kidney disease and end-stage renal failure and this and that. Maybe he has too much despair about his cure and about his disease. So if you find acid force picture resembles the picture of the patient, you can confidently give acid force, and you find that it will help, particularly in the later stage. It's anti-syphilitic stage, because acid force is an anti-syphilitic medicine mostly. Then, this medicine, Plumma metallica. This is my idea. This is my guess about Plumma metallicum, that our homeopathic doctors, at least those whom I know more, because I travel many districts and divisions of our country, and I met many homeopathic physicians. I gave lecture in many places. I taught DHM student, I taught BHM student, I took their exam. So I have some common idea about the stage of or status of our experience and knowledge on homeopathy by the common homeopaths. So this thing tells me that we have less knowledge of Plumma metallica. Many of our homeopaths, I find. Maybe you agree or not, but this is my supposition, that many of our homeopathic doctors have less idea about Plumma metallica. It's a very big medicine, very good medicine, a very fantastic medicine. and it is little more difficult to study its nature. But if you can study and you can grasp the depth of Plummer metallicum, I'm sure it will help you treat many tough diseases, almost incurable diseases, by this medicine. It's a very good medicine, very deep acting medicine. As if, and this is one antiseptic medicine because it works in destroyed structures. The structure, the kidney, the brain, the heart, when they have been destroyed almost, there is fibrosis of the kidney, there is kidney, heart, its tissues are destroyed. In the brain, most of the brain are destroyed. Destroyed means by atherosclerosis, by this is called lacunar ischemia. There are paralysis, and there is emaciation of the body, emaciation of the paralyzed limbs. It has deeper pathology. And but some, not all, of course, there are very good homeopaths in our country who knows it much better than me. But I also say there are many homeopaths who knows less about Plummer metallicum. I hope today I have the desire to share with you the knowledge of Plummer metallicum in general, because I know that if you learn this is a very good medicine, very good and very deep acting medicine. You cannot say the homeopathy can enlive a dead patient, no, but it can enlive an almost fibrosed structure, not all little fibrosed structure, to healthier one. It will stimulate the remaining tissues to be healthy and to take up the action of the dead tissues. It is metallicum. So you see, this is a very good one. Even you can study my note here. You will have here, and I hope you will enjoy it. You will enjoy it. So this much today. I hope I'm not a very good doctor, but I try my level best to learn homeopathy as much as possible, because this is the only one, for which I left allopathy. So I tried my best to learn materia medica, this clinical medicines, repertory, chronic disease, our philosophies, and science of homeopathy. And I always like to share my knowledge which I gained with all others who may find it better for them, and also to take better knowledge from them to enrich my own. So this is all about chronic kidney disease. We finished today. We can take some question from you, and I hope from next week we'll start the Bengali version, and I will invite you, those who did not attend our English version lecture, or maybe you attended, still you attend our Bengali version. I hope your knowledge will be better. You learn it better, you understand it better. With this, I end here. Assalamu alaikum wa rahmatullah. I tell Dr. Anwar Patwari to take the mic and conduct the question answer session. Assalamu alaikum.
Thank you very much, sir, for your excellent speech. আমাদের আজকের ক্লাসের উপস্থিতি যারা আছেন, আপনাদের জন্য আমরা প্রশ্ন উত্তর সেশনটি উন্মুক্ত করব। যারা প্রশ্ন করতে চান, আপনাদের হ্যান্ডগুলো রাইজ করলে আমরা নামগুলো ঘোষণা করতে আমাদের জন্য সুবিধা হবে। প্রথমেই হ্যান্ড রাইজ করেছেন আমাদের বাংলাদেশ হোমিওপ্যাথিক পরিষদের সম্মানিত সহসভাপতি ডক্টর কেএম আলাউদ্দিন স্যার। স্যারকে আমি বিনীত অনুরোধ করবো আপনার মাইকটি আনমিউট করে কথা বলার জন্য। স্যার,
I'm afraid.
স্যার শুনতে পাচ্ছেন?
Yes.
আলাউদ্দিন স্যারের কথা আমরা শুনতে পাচ্ছি না স্যার, আপনার মাইকটি আনমিউট করে নেবেন। অথবা যে সমস্যাটি হয় আমাদের, দীর্ঘক্ষণ ক্লাসে যুক্ত থাকলে অনেক সময় স্ক্রিন হ্যাং করে, তখন অডিও আসে না। কষ্ট করে ক্লাস থেকে বের হয়ে গিয়ে আরেকবার রিজয়েন করেন, তাহলে সমস্যাটির সমাধান হয়ে যাবে ইনশাআল্লাহ। স্যার, স্যার শুনতে পাচ্ছেন? ডক্টর কেএম আলাউদ্দিন স্যার। আচ্ছা, এরপরে হ্যান্ড রাইজ করেছেন ডক্টর রুহুল আমিন। আপনার প্রশ্নটি করুন।
আসসালামু আলাইকুম। স্যারকে অসংখ্য ধন্যবাদ কিডনি ডিজিজের উপর 3টি সুন্দর লেকচার দেওয়ার জন্য। আমি যতদূর জানি স্যার, আপনি রেপার্টরির উপর আসলে ওই বুক বেসড রেপার্টরি থেকে ইজিয়েস্ট রেপার্টরি, কম্পিউটার বা অন্য রেপার্টরির উপর আপনি অনেক স্টাডি করেছেন, এবং কার্ড রেপার্টরি আপনি কালেক্ট করেছেন 25,000 টাকা দিয়ে, এবং রাডার রেপার্টরি সফটওয়্যার বেস এটা শুরুতেই ছিল, সেটা বললেন আজকে $1,000 দিয়ে আপনি পারচেজ করেছিলেন। এই জন্য আপনার রেপার্টরির উপর অনেক দখল আছে। আমি রিকোয়েস্ট করব, রেপার্টরির উপর যদি একটা সেশনের একটা ক্লাস নিতেন, তাহলে আমরা অনেক উপকৃত হতাম। আর স্যার, এখন আমি যে সিক্রেটের উপর কিডনি ভালো রাখার জন্য অনেকেই পানি খাওয়া পারফেক্ট, আবার আপনি আজকে যে বললেন স্যার যে কিডনি ডিজিজ শুরু হয়ে গেলে তখন 1.5 লিটার করে খেতে হয়। এটা কি স্যার ফার্স্ট স্টেজ বা সেকেন্ড স্টেজ, থার্ড স্টেজ সবই একই থাকবে? আবার স্যার, অনেকেই বিশেষ করে ডাবের পানি খেতে কেউ কেউ নিষেধ করে, আবার কেউ কেউ খেতে বলে, এটা কনফিউজড হয়ে যায় আর কি স্যার।
Okay, thank you for the question. First answer is that repertory, yes, it is in our mind. We will take some course of repertory class, and I think it will be class, and I hope that time we'll keep it only for those who are members of Bangladesh Homeopathic Parishad. That's why I will invite others who are not still members of Homeopathic Parishad. Please, you join Homeopathic Parishad, you join strengthening our hand for better homeopathy, for Honeyman homeopathy in Bangladesh. And hope you can attend our classes that time as a proud member of Bangladesh Homeopathic Parishad. Second thing, you said for kidney diseases, in the beginning it is said that one should take little more water. about 3 liters. But when the kidneys functions becomes more and more jeopardized, then we restrict fluid, first 1.5 liter, then 1 liter, and at the end also 1 liter. 1 liter. Why? Because kidney cannot deal with excess water. So if you take more water, this will remain in your body as edema. Regarding your saying that coconut water or something like this, because you know in kidney pathology, that's why you should know chronic kidney disease, its features and its pathology, pathogenesis, so that you can give them level is 3.5 to 5. If it is more than 7, this is incompatible with life. The patient will die. So potassium is dangerous to be more. It is called hyperkalemia. This will disturb the heart and it will stop the heart. And that's why when a patient is in the stage 4, particularly stage 4 or 5, we say don't take food containing potassium. And coconut water is one which contains more potassium. Then we say banana. Banana is one which contains more potassium. Then citrus food, lemon, then as other citrus food, Malta, they contain more potassium. That's why this is the idea, not to take potassium containing food more. They also, we say not to take more sodium, not to take salt, because this will increase his blood pressure level as well as it will retain more fluid in the body. And also we say not to take more protein food, because kidney is unable to deal with more, and there will be more kidney damage. That's why we say to take meat 1 gram per kg maximum. If your patient is 60 kg, he will take 60 gram in one day. It means one big piece of chicken in one day, not more than that. 1 gram per kg body weight. The idea is not to increase creatinine and urea. I hope this satisfies your question. Thank you very much.
Thank you, sir.
Thank you. Anybody else? Please raise your hand. আর কারো দেখতে পাচ্ছি না। কেমাল উদ্দিন স্যার, আপনি কি প্রশ্ন করবেন স্যার? কেমাল উদ্দিন স্যারের মাইকটা মিউট করা স্যার।
মুরবি কোথায়?
না প্রশ্ন নাই। হ্যালো, শোনা যায়?
হ্যাঁ শোনা যায়, প্রশ্ন করুন।
প্রশ্ন নাই, আমি একটা মন্তব্য করতে চাই যে এত সুন্দর ক্লাস যেখানে আমাদের পরিষদের সকলের উপস্থিত থাকা উচিত, সেখানে আমাদের উপস্থিতি সংখ্যা এত কম। এটার ব্যাপারে যদি একটু কিছু বলতেন তাহলে ভালো হতো। জি,
এটা আসলে আগে বলতাম, এখন আমি বলা কিছুটা ছেড়ে দিয়েছি। প্রথম কথা হইলো যারা, আমি বাংলাতেই বলি, প্রথম কথা হইলো যারা আমাদের ক্লাসটা অ্যাটেন্ড করছেন তারা শিওর বুঝতে পারছেন যে ক্লাসগুলা কত ইম্পর্টেন্ট, এবং এই ক্লাসগুলা লেকচার বানাতে আমাকে বহুত পরিশ্রম করতে হয়। এবং কারণ এটা তো আবার মানে রিশিডিউল করে সহজ করে লিখি, যাতে করে আমাদের হোমিওপ্যাথিক ব্রেথেনরা উপকৃত হন আমাদের অনেকের কাছে ক্রনিক কিডনি ডিজিজ পেশেন্ট যায়, কিন্তু এই যে এখন ধরেন আপনি জিএফআর জিএফআর আপনি ক্যালকুলেট করতে পারেন, আপনি স্টেজগুলো বুঝতে পারেন, হ্যাঁ, অনেকগুলা জিনিস আপনার কাছে অনেকটা ক্লিয়ার হলো। ইউ ক্যান ট্রিট ইউর পেশেন্ট বেটার দেন বিফোর। এটা যারা বোঝে না এদেরকে কত বুঝাবেন আপনি, কত বুঝাবেন? যেটা সম্ভব ছিল আমাদের আমাদের সাংগঠনিক ভাবে, সেটার জন্য যারা যারা রেসপন্সিবল, আমি খুব সরি, তাদেরকে বলা সত্ত্বেও তারা কোনো উদ্যোগ নিচ্ছেন না। আমি তাদেরকে এখনো, যদি তারা আছেন মৃদুল কান্তি দে এবং এবং ওর নাম হলো বিপ্লব সরকার, এরা তাদের দুজনকে আমি অনুরোধ করছি, আপনারা একটা মিটিং ডাকেন, সমস্ত